Hello and welcome back to the Ophthalmic Referrals series. My name is Christian, I'm an optometrist, and the aim of this series is to offer some helpful hints and tips to my optometry colleagues in primary care who are making referrals to ophthalmology. In this episode we're going to talk about oculoplastics referrals. As mentioned previously, I'd encourage you to watch the first episode in this series because it will give you the generic information that we should be including in all our ophthalmology referrals, and that will really underpin this series. Please also remember that this is how I would process an oculoplastics referral, and you must use your own professional judgment and follow any local and national guidance that's in effect. It's important that we only send a patient to the oculoplastics team if that particular pathology sits with them. So in essence, I've broken this down into three main areas. You have the eyelids, which covers eyelid lumps and bumps, ptosis and dermatochalasis, and eyelid malposition, whether it's entropion or ectropion. The second category is the lacrimal system, and there we're looking at impaired nasolacrimal drainage. And the third is the orbit adnexa. That could be exophthalmos, proptosis, enophthalmos, thyroid eye disease, and so on. Let's start off with the basics. We want to know what symptoms the patient is having, if any, how long have they been going on for, and which eye and which eyelid are affected. Is this affecting the patient's quality of life or activities of daily living? And do give some concrete examples here, because some CCGs or ICBs will require that as part of the referral. Is it affecting driving, work, hobbies, and so on? Imaging is extremely helpful with any anterior eye disease. So do think about if you can have a dedicated iPod or iPad or camera specifically for imaging in your practice. Do think about GDPR and data protection, so you don't want to be using your own personal device for that. But what I'm getting at is you don't have to have an expensive slit lamp mounted camera necessarily. If you're not used to taking these sorts of images, especially in the context of ptosis and dermatochalasis, the best way to combat any brow overaction, which you can probably see here, this person's making some effort to lift the brows up, which is probably not showing you the worst case scenario here. You can also get a better idea of levator function, is to get the patient to sit with the head in the straight position. Ask them to look down and then stabilise the eyebrows with your thumb and your first finger as they're looking down. Then ask them to look in the straight ahead position, and then if you take a photograph there, that will give you a much truer indication of the level of the ptosis and the levator function. Let's go through some condition specific tips. Starting off with eyelid lumps. I'm not talking about malignancies here or suspected malignancies, but to mention the previous treatment. Have they done all the usual stuff, the hot compresses, the lid hygiene, the lid massage? Have they had any topical or oral antibiotics? For ptosis and dermatochalasis, we've talked about how to get a good image, but how much is it affecting their field of vision? So if you do a visual field test, you'll probably agree that this chap here will have a superior altitudinal defect, and it's very helpful to see just how much that's actually affecting the field of vision. You're giving you evidence to justify treatment. For nasolacrimal, you may find it's helpful to have a generic phrase, so constant watering impairing vision, or constant watering smearing glasses, something along those lines. You'll find that the CCGs are often in favour of these sorts of things, again to justify the referral going forwards. And finally, for entropion, again a generic phrase, so eyelashes are causing persistent and ongoing irritation to the eye, risking trauma to the cornea. That will usually get an entropion referral across the line, assuming of course that's what applies. What should we avoid in our oculoplastics referrals? Well, to say a patient has an eyelid lesion without really qualifying that isn't so helpful. It doesn't really tell us if it's a malignant lesion which needs to be seen urgently, or perhaps a long-standing benign lesion which doesn't. So just a bit more detail there would be really helpful. A bit like with cataract, to say it's affecting the quality of life but without actually giving any concrete examples, you do risk a referral being rejected by certain CCGs on that basis. And to say a patient has a ptosis without again giving any supporting evidence. So is this an acute ptosis which needs to be managed as an urgent or an ophthalmic emergency, or is this a congenital or long-standing ptosis that we don't need to be so worried about? Once we've got the basics right, then we may look to upgrade our oculoplastics referrals. And again, I've broken this down into those 4 categories. So let's start off with eyelid lumps and bumps. We want to look at any risk factors for malignancy, so a history of skin cancer, lots of UV exposure, are they immunosuppressed, immunocompromised? Is there any lash loss associated with the particular lid lesion? And then a bit of detail about the lesion, so how big is it? If you don't have a graticule on your slit lamp, you can carefully hold a ruler up alongside it. What's the surface look like? As we know, ulceration and bleeding are concerning. New pigment and changing pigment is usually concerning. And what's going on around the lesion, so the adnexa? Is the lesion stable or changing, as I've already alluded to? And any lid thickening or swelling is usually a little more concerning. Moving on to ptosis and dermatochalasis. We want to be careful, particularly with ptosis, around potential neurological causes, especially in a more acute ptosis. So motility and diplopia, asking about diplopia is really helpful. Check your pupil reflexes, and as I mentioned on the previous slide, how much of the pupil is actually covered, and you can give that as a percentage. Is the ptosis worsening or static? Is it variable through the day? And this will help to point towards the various differential diagnoses. In terms of nasolacrimal, so potentially or mainly watery eyes, are there any aggravating or relieving factors? So does it change seasonally? Is it worse in the morning or in the afternoon stroke evening? And is it worse indoors, outdoors, or are they both the same? How are the lids positioned? So is there any entropion or ectropion? Is it just a punctal ectropion, so just the puncture that's coming away? What's the puncture look like? Is it narrow and stenosed, or is it wide open, and where it should be positioned? And a measurement, or at least a comment on the tear strip height, can be very helpful. Finally, for entropion and ectropion, it's helpful to know if they've had any previous lid or facial surgery. It's really helpful to know the corneal status. Is there any lag ophthalmos during the day or during the night? And any temporary measures that you've recommended or tried. So managing blepharitis, I suppose, is a bit of a given, but have you recommended lid taping, whether you're taping it open or closed, depending on which it is? Have you tried a bandaged contact lens perhaps, or recommended lubrication? I should also mention that the College of Optometrists clinical management guidelines cover many oculoplastics conditions. I've listed just a few at the bottom here, so they cover nasolacrimal duct obstruction, BCC, chalazion, hordeolum, molluscum, concretions, entropion, ectropion, and I'm sure there's others. So just have a look through and familiarise yourselves with those conditions. Thank you for watching this short video on oculoplastics referrals. Next time we'll have a look at some vitreoretinal referral tips. Thank you.